So let us start our webinar now. Let me introduce our today's chairperson. So please put your hand together to welcome Dr. Hema, professor from Mysore Medical College. She is the ex HOD of Mysore Medical College, and today she will be the chairperson of our MPS webinar. As all of you know that today's webinar is on rational drug therapy, and today's our esteemed speaker is Dr. Nalini Madam. And in the meanwhile, while I was speaking, I just opened the slides of our today's chairpersons, and let me share my screen. Let me share my screen. I'm just trying to open the slides. Sorry for the delay. I'm really, it never happened, and it is mainly because unforeseen reasons where I have to use the different computer at home. Hope all of you are able to listen to me. My voice is clear. Can anyone confirm?
Yes, sir.
Okay, thank you so much.
Yes.
Now, without any delay, I think there is a 13 minutes delay. First time ever in our MPS webinars it happened. I am extremely sorry for that. Even though it is nothing from my side, and since I'm the organizer, I have to take care of all this. So let me introduce. Today's chairperson is Dr. Hema NG Madam. She is the professor of pharmacology at the Mysore Medical College and Research Institution, Mysore. And she completed her MBBS from Adi Institute of Medical Sciences, Bijinagar, Belloor. And she did her MD from again Mysore Medical College. And she is there, she since after completing her MD, she is there as the she started right from the senior resident to current position, and she is continuously working hard to do her best to improve her professional skills. Let me just minimize it. So hope you are able to see the photograph also. So she is in the medical education since long actually. So she was tutor at Adi Medical College, and from then when she got transferred to Mysore, she continued her PG, and then she grew in the department. She has so much of achievements as a PG guide, and she has guided 17 postgraduate students. Very, you are very fortunate, madam. We are still trying to get a PG at our site, and you are very fortunate to get so many, and you are able to, contribute to the profession again. And you have guided the ICMR, STS projects, and 34 publications to your credit. And she is a various reviewer of various journals and delivered guest lectures. And she completed her course in advanced course in medical education. And she is also very much into organizing workshops related to rational prescription writing and under the aegis of medical education unit at MGMCRI. She is also PG guide at RGHS, and she's an NMC assessor too. And I think, to cut short, one of the, good leader in pharmacology family, I can say. And so thank you so much for, being with us today. And I request you to, honor the occasion through the, introduction to the topic and also introduction to our speakers. Thank you, madam. So you can take over.
Okay. Thank you, sir, for the kind introduction. Am I audible?
Yes, madam.
Okay. A very good evening to one and all. So, in an era of rapidly advancing medical science and a variety of therapeutic options, rational drug therapy stands as a cornerstone of modern healthcare. It embodies the principles of evidence based medicine, pharmacological insight, and patient centered care, guiding clinicians in making informed decisions that balance efficacy, safety, and cost effectiveness. Rational drug therapy is the need of the hour, as a proper implementation can prove to be very helpful in reducing morbidity and mortality associated with the usage of drugs and helps improve the quality of life of patients. It also helps in appropriate allocation of resources, which would further help in better availability of essential drugs with genuine costs. It can also minimize the risk of adverse drug reactions and drug resistance. Drug utilization studies, pharmacovigilance, pharmacoepidemiology, pharmacoeconomic studies should be carried out regularly, which provide relevant information that can be used by the government to formulate newer guidelines and policies of healthcare. Hence, rational drug therapy, if practiced properly, will largely benefit mankind. Today, I am privileged to introduce our speaker, Dr. Nalini GK, who will share insights and perspectives on this vital topic. Dr. Nalini GK is a distinguished medical professional with over 28 years of experience in medical education, research, and healthcare administration. She is currently serving as Professor and Head Department of Pharmacology at Sri Atal Bihari Vajpayee Medical College and Research Institute. She is a recognized PG and PhD guide in pharmacology. She has played an active role as MEU coordinator, MEU convener and AMC coordinator. She was shortlisted for the post of Vice Chancellor, Rajiv Gandhi University of Health Sciences. She was the former director at RGUHS, where she led key initiatives in digital transformation, smart classroom implementation, and academic reforms during the COVID-19 pandemic. She is serving as an NMC assessor since the year 2012, contributing to the evaluation and accreditation of UG and PG medical institutes. She has been appointed as a paper setter for DNB exams, and she has been a PhD project assessor by national academic bodies. She serves as an expert panelist for KPSC Drug Inspector Selection, as a subject expert for CDSCO in the evaluation of clinical trials and BA/BE studies. She is the recipient of prestigious awards including Aushad Vijnana Visharada, Bharat Gaurav Puraskar 2024 for excellence in research, education, and healthcare. Jnana Jyoti Trust Award for significant contributions to healthcare education. She has authored 7 book chapters and published over 30 research articles in reputed national and international journals. She has served as principal investigator in more than 40 academic clinical trials, and she has reviewed over 200 academic research proposals and projects. Today, our distinguished speaker will explore concepts about rational drug therapy that help to optimize prescribing practices and minimize adverse effects. So over to Dr. Nalini GK for her presentation.
Thank you, Dr. Hema, from a brief introduction. Thank you very much. Nice.
Thank you.
I'll just share the slide.
Okay.
You can share now, madam.
Yeah. come? It's there?
You have to still PPT. You have to share open PPT, no, madam.
Now?
Now it is coming. So you can make it slide share mode. This one presentation mode. Next one. Next one. Yes, that one.
Yeah.
You can click, madam. Now it is. Now it is
Fine?
okay. Yes.
Yes.
It is moving. Yes, you can start.
Thank you. Thank you for Shivamurthy for the opportunity. Thank you. Nice. Nice to be with you people today. We'll have a great discussion with the rational drug therapy, which is a mere need for the society at present situation. Yes, do you agree with this, everyone? Our moderator also been instructed will have a rational drug therapy, which is one of the foundation for the evidence-based prescribing in a clinical practice. Yes, with this scenarios and few focused, which is focused to the patient-centric case to optimize the patient's outcome. So with this brief ideas of so many things which is happening in and out of our society, we need to rationalize the drug therapy by evidence-based prescribing by our clinicians, not only the clinicians, to be part of integration between all the healthcare professionals. So by these ideas and put forth to the next slide with this contents. Today, I would like to tell about the rational drug therapy, how it matters for us to the society as healthcare professionals, with what are the rights for prescribing and what are the errors will occur while prescribing, how to overcome it, and what are the modes of rational drug therapy which we can enhance our knowledge through simulation and the clinical skill integration, and what is the impact of this rational drug therapy on the public. By this, you'll have your foundations and appropriate case discussions, case scenarios, case makings when this rational drug therapy, and what are the pitfalls of your irrational prescriptions, and the global health initiatives, what are the need to be initiated to use the rational drug therapy, and you'll have your technical and digital health solutions with a ladder, and we'll have a conclusion with your questionnaires. So with this contents and the index of this sessions, I am going to start my session. Why this rational drug therapy matters. So this is, it started in 1985, which is the use occurs when it rises its medication on the diagnosis. First, there should be a rational diagnosis. Without the rational diagnosis, we can't tell the patients receiving the rational drug use. So that is when the diagnosis is being done, the patient receives its medications in appropriate way to a clinical need and then dose which meets its own individual requirements and adequate time and the period with the lower cost to their community. With this ideas of WHO definition will able to tell these drugs are to be rationalized, to be administered in the right drug, indicated to the right diseases, with the right dose, through an appropriate route, and with a suitable duration at the minimum cost. This tells you the rational drug therapy with the minimum cost, which is to be rationalized even with the rationalized drug to the rational diagnosis. So with this, WHO organizes estimated in the recent era that 50% of the medicines worldwide are prescribed, dispensed, or used irrationally. So this alarming statistics highlights its critical gap to affect the outcome globally. It is economically burden to the patient as well as the society. This consequences of irrationality will lead to drug interactions, adverse drug effects, failure in the therapy, as well as disease progression, threatening antimicro resistance as well as the resource and the cost will be increased by the patient as well as the society. This is the main criteria or the scenarios which is leading to a burden to the patient as well as the burden to the society. On this basis, with your why this rational drug therapy matters so. So on this 5 rights of right prescription bothers to know us to tell it should be the framework systematically done to guide this evidence-based medications decisions on optimizing the patient's outcome. So that is to the right patient prescription which should be tailored on the basis of proper indications or the proper diagnosis to the sorry is it clear? Shimurti, yes? Hello?
Yes, madam. Yes, madam. It is clear.
Yeah, fine.
It is clear. Yeah.
So with the right patient, the cursor, right patient, that's to be individualized for the proper diagnosis, the proper indications for the therapy, to establish this alertness to at least the provisional diagnosis to be done. We need to define the therapeutic problems of the patient to tailor the clinical needs of the patient. That is a therapeutic problems to be defined to achieve the goals of what we need to be treated and how the outcome to be expected from our side. That will be considered on its age, comorbidities that is occurred by the taking the history, proper history and its contraindications of the drug. That gives a selection of the class of drugs which is capable to have achieving the desired goal what is expected from our side. This is the right of the patient, right of the doctor and the right of the patient to receive the medications from a healthcare professional or a doctor who is treating the patient. That based on your diagnosis rationality, you can choose the drug which is effective, safe, suitable to the condition and a cost effectiveness. Not only this, we need to bother here when you tell about the right drug. You need to bother to say the safety of the drug, the efficacy of the drug and suitability of the drug which is to be modified when and then wherever we require it. To the right patient with the rational drug diagnosis for the rational disease diagnosis. So when the disease is diagnosed, you need to start with your treatment basis. That should be tapered on a selected medications, which is effective, safe, without the side effect, or which are side effects, but it's suitable to the condition to be bothered. And the cost effectiveness, so it should not be a burden to the patient to purchase the drug. And it is safe. So that can be modified as and when the needs are being required. That's the right drug. On the right dose, the drug which you need to be given, the parenteral, oral, based on the condition. You can't just give the drug when the patient is vomiting. You can't give it oral. So you need to optimize this drug benefits by the right dose to the right duration. So to minimize this potential harm to the appropriate dose schedules and the length of the treatment for how many days we are supposed to give the antibiotics. Or the drugs which is required, the SOS, so now and then required, should be given as the right dose at the right duration or right time. So that bothers to say the right time should the proper drug delivery methods administered to maximize its absorption and they can adhere to the drug which you are prescribed. So that's the most important aspect. So with a right information, when it is comprehensive, instructions or the counselings are being informed consent given by the patient to a doctor when you being counseling for this patient to a proper intake of a drug. So, or taking of a drug from a patient or the prescribes whatever the drugs are being prescribed, the instructions to be counseled in such a way so they should be confident enough to a doctor that what we are talking about, it should be a patient centric and the patient's doctor's compliance should be improved for the better outcome. So with the right information when it is delivered, the adherence to the drug will be maintained by the patient through with the patient's doctor compliance. Doctor compliance will be improved with the patient's care. So this ideas of the 5 R's will tell you, with the better documentation also will tell you the next care to the patient will be appropriately done. So this gives you the complete idea about how this rational prescription to be gone ahead with the rationality behind the drug prescription. So where something goes wrong, what are the things we need to correct? What are the things it should be set? And what are the errors is expected when we are prescribing a drug? So that are the medication errors. That can be your laboratory investigations or the investigations which are come properly or ignored by a doctor for your expected results. And when the drug is being given, so that drug indications will be omitted, or it can be having the expiry date when you are given, that's absorption or observing the drug details when it is manufactured, when it is expiry date to be observed. So before the patient to that instruction is more important. The 5 R's, what are the information of the counseling what you are given should be appropriately given to the patient, where the drug interactions, labeling errors, irrational combinations, all these drug details, drug duplication, failure in your monitoring, or the illegible handwriting when you write these drug names, and inadequate or incorrect instructions given to the patient, or look alike, sound alike drugs, inappropriate abbreviations. All these things are also one lead to a medication errors. This errors can be order or it can be in the transcription error, that can be your prescribing errors, or it can be transcription errors, or ignored allergies, outdated therapeutic plans. So this is a one major aspect which we as a doctor professionals we need to be able to know when we are writing our prescriptions. So that can be based on the pharmacy. There's an integrated way of approach towards the patient's care, where the dispensing of the drugs for to be monitored by patients' identification errors, they are given the drug identification errors, or it can be dose and the route, what were the right dose, what you are thinking right route, or error in your dosing frequencies. If should be given OD or given the BD or twice a day, so that is also error prescriptions that should be monitored, which can lead to an safety measures, which can lead to ineffective or it can be inefficient alert symptoms, or it can be a drug reaction, or it can be drug interactions, or it should be withdrawn the drug when it is not safe to the patient. This is one of the medication safety which alerts to be told as medication errors. So these errors are to be given with examples. We'll talk today about the errors which is happening to determine them in a different aspects. When this is medication errors, that's the prescribing error or the transcription errors, which can be occurred from your inadequate information what you have with us. What is there which should be assessed and it should be protected from our side towards the patient's safety. That is, inadequate information can lead to this medication errors. So we need to have adequate knowledge before prescribing a drug. So this is not only the one aspect, there's another aspect which can lead to an medication errors, that is a service organizer. When the nurses or the doctors, when they have the workload, shift load or work interruption, so all this are the one scenario wise, they have the heavy works also made them disturbed, so that sometimes they are also involved in making the errors. That also be to be avoided, can be avoided by making the academic ambience. That's a everything to be clear, environment need to be maintained, or it is the working relationship should be maintained, that lead to a nursing responsibility commitment of a doctor and the training of the new staff nurses, as well as all the levels of the workers or the healthcare professionals who is working with us. That is a service organization or medical errors which can be determined at the critical care context, or it can be individual factors, that inadequate error notification, which is a concept error which is to be mistook, which is happening to be written in your capital letters. So that is all. Individual factors can also be corrected by your work experience, the level of knowledge what you have achieved, or it can be error notification which can be corrected by your knowledge which you have gained. This is one of the training programs which you are organizing here, which helps also to enhance your knowledge, to write the better prescription and to prevent towards the patient's care. So this is medication administration process. That's a drug to be given oral or to be given parenteral or to be the local. So that's major factors of administrative process or administering the drug or at the administrative level. So that's a stock. When it is procuring the drugs, you need to have this to be well organized medications, prescription or the transcription errors where it is going wrong, medication volume where it should be stored, the medication formats where it should be errors to be avoided, the emergency trolleys where it should be stored, and these are the major things that is should be standardized at the working place, and mention the treatments or with the healthcare professionals, and it should be have the by repetition of all these things, arranging all this at the pharmacy level can develop your experience and improve the storage of the medications or the procurement level at the pharmacy level. So this medication preparations in your administration, that's the route or the administration of nasogastric tube or the dilutions or the physicochemical properties, that is a pharmacokinetic and the pharmacodynamic properties of the drug can also help us to know with the enhancing the knowledge to a better prescription. So this determines the medication errors to reduce the risk and risk determination at this different levels, or the major by knowing your protection factors at the different aspects. So by enhancing our knowledge of today's session with your medication errors towards the prescribing errors, we'll give you examples. That is, here you can see different doctor's name with the signature without the name. So the granicitron, here it is a 3 milligram 50. So that should be noted down when you before administering by the nurse how much the drug to be given to the patient at the different route at the different dose. For example, oxaliplatin infusion which is prescribed for over a 3 hours. So what they happen? They are completed within 2 hours and 26 minutes. So what happened? It should be completely given for 3 hours. What is the difference happened? It suggests the optimum dose, the concentration of the drug that should be attained. It takes it 3 hours to show its efficacy and safety for the patient's recovery. Whereas here it is only given for 2 hours 26 minutes. The optimum infusion time of the specific drug is dependent uniquely on its pharmacokinetic and pharmacodynamic properties. So on this basis, it should be completely given, the drip set should be administered as it is prescribed. So that is a major importance of this medication administration, duration of administration to be followed as it prescribed. That's a one more example I can give you. That's a time dependent antibiotics. That is a carbapenems. The efficacy is linked to the amount of the time of the free drug concentration that stays above the minimum inhibitory concentration. This gives you the time dependent antibiotics. It is dependent on the time or the duration of the time you are going to be administered. This is one few examples of this drug infusion duration. See, Harvard as well, I was telling you the abbreviation there, which can be confusing for us for the medication errors. We need to be vigilant to distinguish between the names. The chlorpromazine, as you see, chlorpromazine, same thing, it looks confusion. That's a sound alike, chlordiazepoxide. So acetazolamide, acetohexamide, like that many examples are given. Hydralazine, hydroxyzine, prednisolone. So these are the different drugs which sound similar, need to be written tall. So to differentiate between each drug, and so the nurses can be easily accessible or read around. So with a better knowledge to explore the drug in a better the receiving and administering the drug to the patient. See, this is one example. One more example I can give you is a look alike and the sound look alike. See, when there is a drug which is placed at the similarly, it looks both, but both are different. Phenobarbital syrup, okay, this is a Gardinal, whereas promethazine H1, it's a phenobarbital, so Finargan. So this is also the looks different in the different conditions and different ways we are supposed to give different indications. See, the same thing, Gardinal, Finargan, that's a phenobarbital. Here, the Evion tablet, Carval Plus, which we do not have. Here, the tablet Evion, vitamin C. Here, there's mannitol injection, osmotic diuretic, whereas the same sodium chloride, which is a crystalloid. So it looks similar. We should be familiarized and we need to label them. These are the drugs are looking alike. So we need to indicate these drugs are to be placed in different place and should be noted down. This is the drug which should be is a crystalloid. This is a diuretic. And the similar way, NeuroKid and the Neurobion both look similar. So this is one thing. And one more example, glycerin again, and the liquid paraffin. So then again, and constipation. And this is the drug which is used for glycerin for a soothing ulcers, oral ulcers. So these are the few indications, different indications which are looking alike with the different drug names. So which is also the error while writing, we need to be careful. So here one more example, why we need to label when that is significantly seen, these are the drugs are looking alike. So this is the one stage where in the pharmacy they should be written and labeled properly, telling these are the drugs are present in these boxes, telling that the same drugs are in the same, the oxytocin, pitocin solution, kenazole, and the Benadryl syrup, diphenhydramine, S-molol, beta blockers. So all these drinks are to be labeled properly and placed in the pharmacy. So by knowing all these things, we'll be able to write the look-alike drugs and the sound-alike drugs and the the spellings where we are supposed to write to differentiate between the drugs. We came to know by this errors, preventing these errors, we can rationalize one aspect of drug therapy. So rationalizing drug therapy is not only the enough factor preventing the medication errors which need to be reported. So later, which can also be learned, this rational drug therapy by simulation and the clinical skill integration. As I told you, that healthcare profession is not a single man show. It is a teamwork which need to be learned by everyone in the similar way. So the group teamwork will develop to have a integrated healthcare outcome to the patients for the better benefits. Okay, this tells us to have a different demonstrated on the simulation patients interview by the prescription cell, which are significantly improved by p-values. So, yes. So we were here with the simulation. So not rationalizing this prescription. The research was being demonstrated telling that the stimulated patients interviews improves your prescription skills significantly. What is that CBME curriculum? Now, structured simulation, structured way of approach to attain the knowledge and the clinical reasoning and the real world scenarios. So, which we are not able to go near the bedside teaching, everything that helped us to maintain this aspects of move in a better way. So the skill based, okay, what is happening? Can you see by the screen? Yeah.
Yes, yes.
Yeah, we
So,
can see the screen. We can see the
thank you,
screen.
thank you.
Yeah.
So on the real world scenario, to reduce the risk of the actual patients and building up the confidence and the developing the competency among the students and among the doctor professionals, nurses, and the pharmacists, which is the integrated medicine, what is coming approach at the building up the gap between the knowledge and the practical prescribing skills for the well clinical practice means essential skills which is required for the healthcare professionals was developed the confidence that was the study was done telling 92% of confidence boost was done by the simulation methods. 78% was improved by the skill improvement measuring the grade with the prescribing accuracy. By telling this the simulation based education nowadays the CBME curriculum providing the essential bridge between this classroom learning and the bedside practice, allowing the students to develop prescribing competence in a controlled and a supportive environment. That is what is the ambience. That's a which is being developed in our setup to develop a well understanding prescribing skills for an evidence-based real scenario case-based treatment for the patients. This was developed among the students. So now at the public level, how this impact of the public level and the rational drug therapy. This irrational approach will affect the significant treatment or the global impact among the healthcare system as we have been talking on the economics and the population health equity. So that can be leading to an inappropriate prescribing or irrational prescribing, developing the antimicrobial resistance, that's the inappropriate antibiotics towards the untreatable drugs, untreatable diseases. So, which is not on the over-the-counter drugs or the orphan drugs, which is being smart drugs, which is being need to be used, not to be used, need to be have the knowledge of it, which will avoid this antimicrobial resistance, antibiotic resistance, that is the drug resistance in infections, which are responsible to be estimated as per the global level 1.27 million deaths every year because of resistance. That's the reason nowadays This is coming up with antimicrobial stewardship program. And we are losing about the antibiotics which are at the stock level, which was at the levels of penicillins which are used in the treatment. Now it has come to the cephalosporins, aminoglycosides, and fluoroquinolones, broad spectrum. So many new generations, new antimicrobials, everything. So that's a better the disappearance of the old new penicillin group of drugs. So that is what that will lead to an economic burden on the society. The financial strains of the irrational drug use and the prolonged hospital stay because of the irrational treatment and their additional diagnostics, what we are dependent upon towards treatment aspects, and their more expensive treatment, the cost effectiveness of the drugs, which need to be precision medicines, and the costing this healthcare system have been billions together annually. This is the burden to the public by this irrational drug prescription. And not only this aspects lead to, there is something which is happening is your health equity concern. The vulnerable populations, which is often burnt to the suboptimal prescribings, widening its health disparities and reducing the public's trust on the medical care, undermining the universal health coverage goals. So this is what happening nowadays. So we to be the better side with the Google, the now we had the problem raised. So everybody should have the commitment towards the healthcare system. So they do respect, so that we can be able to overcome all these problems, burst open this prescription in a better way to widening this healthcare system, reducing the public trust in the medical care. So that should be created. They should know their commitment towards the medical system. So that only not only this, with this foundation on the appropriate clinical decision making towards your diagnosis, towards your care, should be based on the hinges of systematic approach. That is the integrated multiple factors, that is the optimizing the patient's outcome and upholding this ethical standards. That is more important, the pillars of ethics. Among the pillars of ethics, to prescribing will be the safer side when we have the evidence-based medicine, which can be with the evidence that can be integrated with the best values of research evidence, clinical expertise, and the patient values form the informed choice. So that will help us to have this drug to be given to the specific diagnosis, specific condition they have. So on the clinical guidelines, we'll be able to adhere to the standards of evidence-informed recommendations and the protocols for the disease management. This tells us thus we need to have the standard treatment guidelines of all the conditions what we are in and out of our hospitals, in and out of our healthcare systems, which maintains the protocols for the disease management. So that gives a complete evidence-based medicine to expertise ourselves to give the informed choice or the specific drug to a specific disease. So that will be leading to a patient-centric care. That is tailoring this interventions to individual patients so you can modify the required drug to reach the values, goals, and unique in its health context. This is a patient-centric care. So by making all these things, we need to share this decision making collaboratively, engage the patients in the treatment choice, ensuring this patient's informed consent and the active participation is more important by counseling them collaboratively, getting the confidence of the patient to adhere to the drug in its appropriate decision making to a treatment. So thereby there will be benefits towards the and the risk will be balanced with the over the benefits of the treatment. The systematic weighing of this potential therapeutic advantages against this possible harms, adverse effects of the each patient will be appropriately encourage to them to report the areas, report the side effects that are side events, adverse events that are causing to the patient to the doctor. They'll have the confidence of the doctor, which will be developing the rapport between the doctor patient, then the complaints will be improved. This gives you appropriate clinical care to the patient, towards the patient. So this common pitfalls which can have the irrational prescribing, which led to an inappropriate antibiotic use, which need to be recognized at the prescribing errors, developing the sound clinical judgment at the protecting the patient's safety. So that is an upper respiratory infection that will be contributing to the antimicrobial resistance unnecessary. That's over-the-counter drugs. They go take the drug from the pharmacy, which nowadays, whichever the infection is occurred, you just take amoxicillin, just you take amoxicillin, irrespective irrational use of this inappropriate other antibiotics to the specific conditions. So that will lead to an resistance of the antibiotics. Now there is a reason the antimicrobial stewardship programs are being started to prevent this resistance. So that's a wrong drug selection. Choosing the medications towards this, for example, it's anti-motility agents, that is with an infected diarrhea, which is not required. Why the infection again get worsened? So that lead to a prolonged outcome and the prolonged illness, worsening the outcome of the patient. So that wrong selection should not be done. So you need to prevent by giving the drug which is specific to the disease. So that should be given with the right drug, the right dose, and the right route. Incorrect dosage also will, with the incorrect treatment duration, route and intravenous, that's what we have been with the cost of it will be a burden to the patient. Thereby, unnecessary escalation of this broad spectrum, we have given the narrow spectrum, broad spectrum initial itself. Excuse me. And then you narrow down. So it's better to have a narrow down of drugs, and then the coverage of the spectrum will lead to a cost effectiveness. The more cost effectiveness can alter the equality effect on the safer side. So this is unnecessary escalation can also be pitfalls of your irrational prescribings. By this, we can go ahead with the global health initiatives. Not only with all these things, irrationality will help. So we can improve the global health system by the rational drug use. That is, you are developing the evidence. We have been talking about the evidence. So the evidence-based medicine can also help us to integrate international level to efforts to promote the rational drug use worldwide, challenging from the policy formation to an grassroots implications. What is this grassroots implication which can be corrected by developing the WHO essential drug list around 356 or 58 drugs by 2024 or 150, which prioritize the safe, effective, affordable medication list, which tells us the or developed within 150 countries for the national drug policies. This is one global initiative which has developed to prevent this irrational pitfalls of the irrational use of the drugs, pitfalls of the prescribing errors, transcription errors. All this can be avoided by using this WHO essential medicine list. Not only this, with the regulatory frameworks, which will robot policies are being, regulatory bodies are being ensured by giving the drug quality, availability, and appropriate use. Approximately 80% of low and middle income countries were established by the national drug policies. So by these national drug policies, we can strengthen the healthcare system by enhancing or procuring this supply chain management, and distributing vitally to increase 60% of the low-income countries. So thereby, the fully functional drug supply chains are maintained throughout. So by this, there will be a capacity building among the healthcare workers, which equip the prescribers with the knowledge of evidence-based decision. There were 60% of the increase in the trained professionals, the rational drug prescribing over the last decades. So this is what is happening by the healthcare workers, the integration among each other. By this, all this pitfalls to be corrected at the global level, thereby will monitor the system for the drug use patterns. That will be surveillance tracking the consumption adherence, which is being after the counseling for the concern of a patient, and then advising them to have the events. When there is an event, you need to report them and identify the drug administration, drug monitoring, and drug safety measures, and reporting them at the medication error level, transcription prescribing error level, and then the criticized drug to drug interaction level and the safety level. Thereby identifying every areas will also improvement will occur. That is, unfortunately, we do have only 50 countries regularly monitor this antibiotic consumption data. So we should be among with them to one of them, the 51% of our state-wise, national-wise. Okay. This is the, not only by all these aspects will be able to improve our rational drug use by technology. We talked about the simulation, we talked about the global level. There is another level where we are technology and the digital health solution also transforming this rational drug therapy and improve the prescribing accuracy to enhancing the patient adherence and the public health surveillance. How we can do this? Nowadays, we are at the digital era. That is electronic prescribing. So we will not have any problems. That is the small letters, the cursive writing for the prescription. Thus, streamlining the prescription workflow, significantly reducing medication errors by 70% and improving the patient safety. Not only this, with the electronic system, prescribing with the on the streamline, here we'll have the clinical decision support and the real-time evidence-based guidelines online itself, leading to 30% of the inappropriate drugs choices, where will help us to prescribe appropriately. And AI assistance, now it has been come out for the drug selection, leverages the artificial intelligence for the personalized treatment identification and optimize the drug selection up to a 20% for the complex cases. So this will, by the knowledge, all the things will be integrated to help the assistant AI system to give the support to optimize the drug selection. Not only by this, on the COVID-19, the telemedicine and the remote care has given a lesson for us. Expanding the access to healthcare and the remote prescribing has increased from 0 to 400% in now the recent years. Not only by that, the mobile health application, which also adhere the reminders, so we can remind, we are able to remind ourselves that we have taken the drug. We need to take the drug at the right time, at the right dose. Everything, educations are the mobile healthcare application is improved its patients' complaints by 15 to 20%. The digital surveillance systems are the real-time monitoring the drug pattern adverse event has been outbreaken nowadays by detecting at 70%. So this is a technology, and the digital health solutions also will help us to rationalize the drug therapy and improve the prescribing accuracy. So enhancing all these things, what are the challenges we face it while doing this rational drug therapy? While doing all this rational. So this to be implemented in a clear benefit way to faces this numerous systemic, professional, and the patient level obstacles globally. So what are those things? systemic constraints, the fragmented health system. So, insufficient funding, yes, we do have that. The lack of coordination hinder the unified effort to promote the rational. Promote the rational prescribing practices. This is a systematic constraints which is leading to a challenges what we are bearing it. So that's a challenge. The resource limitation, the government set up, the low income settings, scarcity of essential medicine, diagnostic tools for the specific diseases, training personnels, which is not, and which need to be trained each other. So basic infrastructure impede the effective drug management. So this is one aspect. And not only this, provider resistance. The healthcare providers often exhibit resistance to adopting new guidelines due to ingraining habits, lacking of continuous education, or skepticisms about the new approaches. Okay, this is enough. This is enough. So that's not should be the approach. This is one approach, the provider's resistance. So regulatory gaps, outdated or unenforced policies, weak regulatory bodies, and insufficient monitoring of mechanism-related loopholes for the irrational drug use, and the patient literacy. Low health literacy among the patients lead to poor adherence, misunderstandings of the communication, what we have done, of the drug instructions, and inappropriate self-medication process. Not only with this challenge, we do have another challenge, that is the infrastructure challenges. Lack of reliable electricity, what we faced today. Not only that, the internet access, secure storage, where the cold chain facilities in remote areas, not only remote, we are with this areas also we are face these problems, and to maintain the drug quality based on this drug quality and availability. So this is the one thing with the rational drug use, which will be headed with many challenges we need to during our implementation. So with the future directions or the innovations, we can overcome this. This is the landscape for this national drug use, rapidly evolving to the global push for personalizing the efficient healthcare. That is personalizing medicine and the pharmacogenomics, tailoring this therapy-based individual genetic profiles to optimize this efficacy and minimizing the adverse drug reactions. So the individual genetic profile will help us to give the specific, optimizing their efficacy and minimizing this adverse effects. Not only this effect, the precision dosing algorithm, the utilizing the AI and the real-time patient's data, the calculating the exact drug dosages, reducing the errors, maximizing the therapeutic outcome. This is a precision dosing, the PDOTs, the precision medicines, and this will help us to optimize the therapeutic, the maximizing the therapeutic outcome. This is not only that, the blockchain for the supply chain integrity, that is securing the pharmaceutical supply chain, preventing the counterfeits, and then in the ensuring this drug authenticity from manufacturer to the patients. So the chain is well maintained. Not only this, this AI in its discovery and the prescribing accelerates drug development and providing the intelligence on the evidence-based recommendation for the prescribers. So that's not only this aspect, there is one more important what we are within, that is a seamlizing the integrating the prescribing data with electronic health records for the holistic patient's view, enhancing the coordination and safety. Not only this, that the global collaboration is important to have this rational drug therapy by fostering the international research, knowledge sharing, policy development, and to an advanced rational drug use worldwide, which uniform the rationalized drug use worldwide. By how is this possible? How is this possible? This helps us to know this rational drug policy formulation by the Crystal Albert's ladder. So this Crystal Albert ladder tells us we need to have an evidence-based medicine. Sorry. So this tells us we need to have this crystal ladder for the adequate supply of evidence drugs. This evidence drugs or evidence-based medicine. This is by banned hazardous drugs and irrational drugs. Banning the rational and hazardous drugs, adequate supply of essential drugs, use only the generic names, ensure the quality of the drugs, ensure the correct information, ensure the ethical marketing of this, ensure a reasonable price of the drug, and promote the indigenous research and development, plug out all the legal loopholes, and then we'll have our better CME programs, what we are organizing from Shivamurthy today. So that will develop you the rational drug for policies. This is the ladder which helps us to maintain the healthcare professionals in a place with a better rational drug therapy. So not only this, with all these scenarios, all these ideas, we'll be able to have our role, prevent these errors and the inappropriate medications by the physician, by the pharmacist, and the pharmacy nurses, by preventing at the healthcare professionals by the physicians, are to conduct to the patient's assessment how we can prevent this problems of errors that has been occurred to rationalize the drug therapy. With this knowledge, we can conduct through the patient's assessment, write a clear concise prescription, consider potential drug interaction, communicate the treatment plans effectively. This is we can prevent by this, by how it can be identified, detecting them, identify the inconsistencies in patient's presentation of the lab results, recognize the medication's side effects, as well as monitor them, or that manage this correct errors through the appropriate intervention, collaborate with the healthcare team members, document the treatment changes accurately. This is a modification of the drug whenever it is needed. So that can be possible when there is a rational drug therapy. This is the other consultants and the physician's role towards the rational drug therapy. So this is the role of a nurse and the role of a pharmacist. By preventing this, review prescription properly, which has been prescribed by the physician or the consultant accurately. You can see this, or when they are not able to communicate with them, interact with them, and know the particular dosage form of the drug and allergy status of the patient, then that is also one way we can rationalize the drug use to the patient by educating them on the proper use of the medication. So this is one aspect. But how can it be possible? By identifying the errors during the dispensing, alert clinicians to the potential drug regimen issues, or perform the medication reconciliations. So there will be one of the pharmacist role is major high alert drugs, high risk drugs, and high emergency drugs. Everything we need to be the errors, what and all we have discussed previously, they need to be placed properly from their point of view, which has been with their knowledge enhancing. So thereby they can manage the drug information and they can counsel the patient, suggest the alternate medicine if needed with the prescription of a doctor, with the prescription of a physician. That is must. Monitor the effectiveness of the drug therapy. This helps the role of a pharmacist towards the patient's care. So what's the role of a nurse to preventing this errors and rationalize the drug use? The double check of the medication orders that has been prescribed, verify the patient's identity before administration, monitor the patient's response closely, and report consent promptly. These are the few terminology which will be able to prevent and safeguard the patient. So how can it be possible? That by detecting the errors during administration. So now this material vigilance, it can be one of the incidents which has been occurred by the drip set. That's in our scenario, there was a drip set which company, by giving the same drip set, 3 drugs was given. That's a paracetamol, ceftriaxone, and the pantoprazole. All these things are being given by the same drip set. There was no reaction for the other drip set, whereas with the drugs with the this drip set, which has the X drip set, which has led the reaction to subsequently 3 or 4 patients. We came to know it is not the drug causing the reaction, it is the drip set is leading to a reaction or the flu-like symptoms to the patient. So that was withdrawn from the market. So this is identification of the errors during the administration of the drug or the adverse drug reaction that is occurred to the device. So the route when we take it, the error are that it should be administered parenterally. Yes, it should be administered. We need to give it only parenteral route, not the oral route. So the communication concern to the healthcare team, if there is any issues or not able to understand, they need to communicate and clear, then they should be able to prevent and improve their patient's care. So that will be managed by implementing the interventions to identifying the issues, educate the patients about the medication use, and the document the relevant observations accurately. This is more important when this is the scenario occurs. For example, there was a case when their patient was on digoxin, more than the digoxin, that's a 0.625 milligrams. So when there was a patient as they've given the 625 milligrams, triple the dose of this drug. So that's one more example. There's a morphine drug was given where the poison has been occurred to the morphine. So the antidote, the patient was asked, the nurse was asked to give the naloxone. There the lanoxin, the digoxin, the brand name was given administered to the patient by storing that in an syringe. When the patient is not recovering back, the doctor asked the nurse to reload the lanoxin. So there is a communication gap between the doctor and the nurse. Lanoxin, naloxone. So this is more important. The pronunciation and the documentation and communication is more important between the doctor and the nurse towards the patient's care and towards by the rational prescriptions. So the key takeaway messages for this rational drug therapy is the cornerstone for the effective healthcare system. I just tell you to know that the professional imperative, the rational drug therapy is the fundamental to the patient's safety, treatment efficacy, and resource optimization for the healthcare professionals. So the education is paramount. You need to continuous education and lifelong learners, robust training program, and essential to equip prescribers with the knowledge and skill for evidence-based decision making and global impact. Promoting this rational drug use has a profound implication for the global healthcare as well as the combating the antimicrobial resistance, ensure the equitable access of this medicines. The call of this action of the professionals are companion with the essential medicine prescribings, invest in the continuous learning, advocate for the policy change, empower with the patients through the education. That is, the educated patients on their medications, fostering adherence and clinical health literacy to prevent the inappropriate medications, self-medications. This advocate, they engage them in the national drug policies, educate them ourselves, each other, and as well as interdisciplinary collaboration will enhance the knowledge. This is the improvement all throughout for making the better prescribing and optimizing this better patient's outcome. So this concludes our discussion, building up the rational drug therapy in a future, resting not just a scientific breakthrough, but on our collective commitment to responsible evidence-based care for every patient everywhere. Our journey through the rational drug therapy has eliminated its fundamental principles in transforming the power of what we have been discussing, the digital health, persistent challenges that we are facing and demand our attention. So the path forward is paved with innovation, collaboration, and an unwavering dedication from every healthcare professionals. So this concludes by telling you thank you.
Thank you so much, madam. It was a really, very nice discussion. It went on, and now I request our chairperson to, have some remarks. After that, one question was there, so we'll take that question and then we'll wind up.
Yeah.
Thank you, madam, for your valuable insights. You have very well brought out the concept of rational drug therapy, and you have mentioned the various medication errors. You have given good clinical examples, and also you have brought out the various global initiatives that have been taken to overcome the irrational drug use. And also, in addition to that, you have mentioned about the various technology and digital health solutions which can be taken up to bring about better rational drug therapy, and the various challenges and barriers to implementation of these technology and digital health solutions. So overall, it was a very good presentation, and I am sure that the audience has benefited by this presentation. And over to the audience, any questions they can ask.
Yes, madam, you can stop sharing, madam.
Yeah. Thank you.
Yeah, thank you so much, madam. So actually, it is very nice. We had a very great opportunity to learn from you, and I think the discussion went so nicely that you elaborated about the latest updates, latest interest areas and all. There was one question. There was one question related to, like, if there is one question from a pharmacist, I believe. So he mentioned that if there is a if there is a FDC, can we issue two generic medicines or two drugs with the similar composition or similar dosage formulations, but they are not same. They are different. Like they are individual products. Can we suppose two drugs are there in an FDC? So can we issue two separate medicines? For that prescription, or can we replace with it individual drugs? This is something they asked. Can we get some discussion? Can we have some discussion on this?
Yes, can we put a words few? This is an evidence-based medicine. So what we are being with this, the rationalizing the drug therapy will be accountable for the evidence-based. So better to follow the evidence-based medicine or evidence-based list of drugs. The 375 drugs or 58 drugs are there in the evidence essential drug list. So
Yeah.
the essential drug list will tell you, is it rational or irrational? So when there is a rational, they need not bother to say individual drugs to be prescribed. So it is already rational, it is proved. So there will be everything we know, the physicochemical properties we know, drug interactions we know the side effects of that drug, or that's the drug promotion literature is good literature has been given. So the essential drug list will help us to give the fixed dose combination. When it is followed, no problem. So if at all, they wanted to have these drugs only, which they want. No patient's choice has come now.
So
So,
suppose if
uh,
that particular FDC is like, if some brand or some, FDC is not available,
yeah,
their question is, can we issue the individual drugs?
yes, yes. But it should be the same dose of a drug, the same
Yeah,
route
same,
it should be selected, and
same.
the requirement should be fulfilled towards
And
the patient safety.
suppose, FDC is a modified release drug,
Yes,
then the individual drugs also should be the same modified
same,
release
same,
drug.
same. Yes,
We can't interchange the, sustained release versus modified release,
modified release. Yes,
or a
yes,
simple release or a
yes.
coated
Extended release. Yes,
release.
film coated. Yes,
Yeah,
that's
yeah.
the
Oh,
reason.
so thank you so much, madam. Now we
Yeah,
have Dr. Geraldine Sanjay, madam. Can
yeah.
you please ask, madam? Actually,
Okay, thank you, Dr. Nalini. That was an
Thank you,
excellent
madam.
presentation.
Thank you, madam.
However, I was now in my practice and, my own care for my body.
Yes, ma'am.
I was thinking of, see, this was, of course, rational drug therapy.
Yes,
But
ma'am.
then now more and more people are moving into nutraceuticals.
Yes, ma'am.
See,
Yes,
we
ma'am.
are giving these drugs based on the germ theory of disease,
Yes, ma'am.
and also since we are going into genomics,
Yes, ma'am.
more and more we are discussing and learning what exactly causes a disease in a healthy person and
Yes, ma'am.
how to restore them back to being healthy.
Yes, ma'am.
So the
Yeah.
focus is the human person, very unique and with the specific needs, which
Yes, ma'am.
was dealt with by Ayurveda and some of the other in natural based medicines,
Yes, ma'am.
naturopathy, home remedies, and so on.
Yes, ma'am.
So, and being in a premier institution like Atal Bihari Vajpayee,
Yes, ma'am.
and we are going into integrative medicine, homeopathy, this whole discussion going on about health and healing,
Yes, ma'am.
and training, and also because you were talking about global
Uh,
collaborations, right?
yes,
I
ma'am.
feel we need to also work on what is the Indian ways of, and most of our people actually try every other system also, though
Yes, ma'am.
we are not giving it the legal support that is
Approval. Yeah.
needed. Yeah,
Mm.
see, homeopathy and Ayurveda, so many people choose different methods of healing themselves.
Yes, ma'am.
And being a teacher and in a pharmacology is basically the whole chemicals, right? Biochemistry.
Yes, ma'am. Yeah.
So I'm hoping that also we can work towards these nutraceuticals, diet, in restoration of health.
Yes, ma'am.
Okay. What is
Yeah.
your position on this? What are the steps you are
Ma'am,
taking to
ma'am,
teach our students? And,
ma'am, here.
yeah, thank you.
Yes, ma'am. You're to the right point nowadays. This is what is happening in the setup. In behind the views, they'll be telling you can take this drug, Leave 52 for the liver disease. So, which is not under the prescribings of this allopathic medicine. So, there will be a combination of drugs being consumed by the patient. What do you mean to say, no, ma'am? So, in this view, we should be able to know what are the food drug interactions. They should know the homeopathic or the Ayurvedic drug interaction with the drugs, what they are consuming, with the medicines of allopathy, what they are taking. The antibiotics is common for everything, whereas the drugs which are taken, the natural source or the nutraceuticals or the homeopathy medicine, Ayurvedic medicine, they should know their limitations where they are taking the allopathy. But open wise, the patient should inform the doctor regarding the drugs they are being consuming. Do you agree with this, ma'am?
Yes, madam. That's called
Yes.
collaborative negligence, no? I mean,
Yes, ma'am.
corroborated.
Yes.
Yeah.
Yes, ma'am.
So it's the patient, is the person who's in need of help and care.
Yes,
I
ma'am.
think also when we are talking about digital health and
Yes, ma'am.
artificial intelligence, we
Yes,
are
ma'am.
in the we are in that cusp of losing our clinical skills and
Yes,
really
ma'am. That is a
caring for the.
simulation. That is the reason I introduced the simulation word. Real scenario. We can't go near the patient and learn. Nowadays, the patients are also well smart enough. They won't allow all the
Mhm. No,
students to
madam, that's, I
learn.
mean, listening,
Yes.
of course, maybe
Yes.
hands on, maybe some, in fact, the
Yes. Yes.
radiologist the other day,
Yes,
when
ma'am.
they were discussing breast cancer,
Yes,
One of the
ma'am.
doctors was suggesting, apart from the clinician, identifying the tumor, the
Yes, ma'am.
radiologist should palpate the breast,
Yes, ma'am.
apart from looking at the images. So I don't know how
Mm.
far, that would be feasible, right?
Yes, ma'am.
That clinical, where you actually touch the patient, listen to them, and, I
Yeah.
think that is one of the drawbacks with our kind of education. And I don't think artificial intelligence and, will help with the person to person kind of learning we learned in our MBBS levels, where
Exactly.
yeah, I think that also should be incorporated with all the other basic sciences, particularly
Yes.
anatomy, physiology, biochemistry, and pharmacology.
Yes, ma'am.
When you're talking about integrating with clinical skills,
Yes, ma'am.
we should really interact with the person, that personal touch, I think, is very important, and which people
Important.
are missing, particularly old people and children, no?
Yes, ma'am.
That caring, you actually, that kairasi, or that healing power goes
Yes, ma'am.
from the doctor.
Yes, ma'am.
Apart, I mean, I experienced that with the doctor friend of mine, pediatrician. For my
Exactly,
children,
ma'am.
I
Mm.
used to take my children to her, and just when she's examining and all that, they would get better. It was not the
Yes,
medicine.
ma'am. That's what. It's not the medicine.
So that humanity and
Exactly.
empathy also, Dr. Nalini, I think we
Yes,
should
ma'am.
really
Yes, ma'am.
teach our children, no, our students.
Exactly. Yes, ma'am.
Okay. Thank you, madam.
Thank you, madam.
Okay, so there is one more person who has raised, Moon Rai. Moon Rai, can you unmute yourself and then quickly ask the question? I hope this will be the last one. Moon
Yes,
Rai.
sir. Yes,
Yeah.
sir. Yes, sir. First of all, good evening, everyone. And ma'am, it was very nice presentation from you. Ma'am, as a
Thank you.
medical student, you can say I have only one question to ask. Ma'am, as we all know that currently like the new generation influencers, you can say, they are prescribing random drugs and everything online without having any evidence about that. They just google it, they just ask chat gpt, and then they make video and everything. And here we are talking about the evidence based medicine. Don't you feel that this is also one of the gap that we regulate who is telling what on social media, as well as what they are prescribing? Because most of these people who don't know anything about any medicine, they just saw these videos and they take that kind of medicine from directly from the pharmacist and directly from their nearby shop. So I
Yeah,
think this
yeah, we got your point. What you are saying is that, like how to regulate the social media,
yes,
guiding the
yes,
people,
sir.
right? Okay, we'll discuss that. Madam, please.
Yeah, this is the right one. That's the reason why I included the role of a pharmacist.
Yeah.
This is the a major idea behind the role of a pharmacist being included in the slide presentation. The role
Yes,
of the
ma'am.
pharmacist is not to give the over the counter drugs, and not which is not prescribed by the doctor. With the approved prescription only, the approved practitioner signature only, the dispensing of the drug should be done from the pharmacist. So this is one which helps us to maintain this gap, the avoid this gap. So that one more thing, what you told is the by searching the Google and they'll collect the data. Who has created this? It has been done by us. So what are the things? What even though they collect the data, they should come to a doctor. Just they get the confidence of the doctor that the treatment what I'm taking is right or wrong. They should confirm it and then go to the pharmacy to take the drug. That gap will be avoided. What you are talking about? Yes.
Yes, ma'am. And
Yeah.
for this only, I want to add one more thing, that
Yes, ma'am.
I have been it's like I have been in my just one more minute.
Hello.
Sorry,
Hello.
sorry, there was one call. I'm sorry, I'm very sorry. So, sir, I was telling that I have been in my village since past 1.5 months, and I just saw what is happening in like real grassroots level, that is in village. um, I have saw 4 cases. I just want to give you a quick information how it is very difficult for a village people in India, that is too in northern side, to have a basic medicines like paracetamol, Montelukast, um, and basic coughs, not cough syrup, but basic medicines for cough and cold. So my grandfather, he was very sick, and
Yeah, please go ahead. Hello. Yeah, we lost you. Can you repeat?
doesn't find one Montelukast in entire village. Just asking pharmacist, healthcare provider, and you already told me that there is. Hello,
Yeah, yeah.
am
Please
I
go ahead.
audible, sir?
Yes, yes. Please go ahead.
Um, uh, so I was saying, ma'am, that you already told in your presentation that there is some resistance in grassroots level, in doctors, in pharmacists. But apart from this, how can we bridge this gap? How can we make basic drugs accessible to grassroots level and in the village? It's like basic thing. We as a pharmacist definitely don't have touch with the patient, but we are like very innovative person. So can we bridge this gap so that a basic person in village have some medical
Okay.
facilities or thing?
What I'm saying is
Yes,
that,
sir.
like, what you are asking is that, like, is there any possibility of giving prescribing rights to pharmacists? That's what you are asking?
No, 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 no. I was saying, like this telemedicine,
Hmm.
uh, we whole pharmacology team, can we build something um, like telemedicine from
Yeah,
which we
that,
can give medicine? We prescribe medicine because we are doctor and we have rights to prescribe
yeah.
uh, in grassroots level, like in village level, some
Yeah.
telemedicine, something.
Yes, like what is happening is that, there is a telemedicine, that's a big project that is being introduced. But most importantly, that, that was, I think that was very much successful during the
COVID.
COVID time. But after
Mm,
that, everyone is busy. And again, what you see that, like we are 140 crore population, and
mm,
the kind of, even though we are producing good number of doctors, I would say that even 50% will not practice. Okay, major, some of them will go to PG studies, some of them will go to some further studies or foreign countries, or they will be practicing means they will be doing pre and para work. So then finally you will end up having very few people working in the clinic, and I feel that that is not sufficient. And as you rightly pointed out, even in the rural areas, you are not finding the right kind of doctor. Okay, and
mm,
one more problem is that, if you go to rural areas, yeah, qualified doctors are there, but people don't go to them because they do a systematic study and they of the patient, and they prescribe a lengthy medication. They want very quick one drug, means one paracetamol, one amoxicillin, very irrational prescription they want. So all
mm.
these things, even I experienced while I was practicing in rural area. There we are, there is a long way to go. The long way to go in implementing rational prescribing practices or rational drug therapy practices, and we should educate more and more. And the what we educate now here, it should also reach the grassroots level people also. And supply of medicines, again, Janaushadhi Kendras are opened everywhere, and government is making their effort. But also quality of medicine is the another, issue that is propping up again.
True, sir.
A lot of issues are there. Again, India is a big country, and when I was interacting with the DCGI, in one of the meetings, when we asked them that why don't you ask for BAB studies for every drug that is released in India as a generic, they said that, our people are not able to afford. offered, it means that it's okay. It means they are indirectly saying that it's okay to give poor quality medicines. So I'm not blaming them at the kind of manufacturing that happens for the international market is different, and the kind of manufacturing happens for the local market
It's
is different.
completely different. Yes,
Yeah,
sir.
even different, so like this. So I believe that, I think, like there is a long, means it will keep on going, whatever we discuss. The basic principles, I believe, we have discussed. Now I'll hand over mic
Yes,
to
sir. Thank
Dr.
you.
Hema
Thank you,
madam.
sir.
Yeah,
Hmm.
Dr. Hema madam. So can we have the concluding remark from your side, madam?
So, so finally, I think that it was a very informative talk by Dr. Nalini, and she has very well brought out the various aspects related to rational drug therapy. And I hope you all take home this message, how you should implement rational drug therapy in your future practice, whether you are doctors or pharmacists or nurses, whatever healthcare professionals, you should implement these in your future practice. So, thank you for the excellent presentation, madam, once again.
Thank you, Hema.
Thank you.
Thank you.
Thank you, everyone.
Thank
Thank
you,
you, sir, for
Shivarti.
this
Thank
opportunity.
Let me know,
you.
like,
Thank you all. Good
Thank you,
night.
ma'am. Good night.
wait,
Thank
wait,
you,
wait,
ma'am.
wait, wait, please, please wait for a minute. Let me honor our, today's presenter, today's speaker with the certificates, and also I would like to present this certificate to Dr. Hema madam for chairing the session. Congratulations, madam, for making this a successful event, and thank you so much for taking us through this presentation. From the Medical Pharmacology Society, we are honored to have you. Next, I would like to honor Dr. Nalini madam. Actually, your presentation was very nice, madam. I'm sorry for some of the unforeseen incidences that happened in between.
It's okay.
It was very nice. Unfortunately, like no, through this, I would like to request all the participants to not to share the links outside our groups. It only happened because of that only. But anyway, we are very resistant people. So with all the difficulties, we could successfully complete it. And even though the complete event is recorded, I need to edit little bit because of all these issues. I'll download and I'll try to make a nice upload, and I'll again share all the presentation as one video. So my editing skills need to come in here, and I will do that, and I'll upload again. So thank you everyone for joining us today, and I will share the certificate links to all the people who attended today. So did I show the screen? I think I'm sorry. I think I did not share the my screen only. No? Let me just share the screen. Just okay. So I think sorry for that again. Today a little bit
Thank
yeah.
you.
Certificates. Hema madam, thank you so much for your presence and
Thank you.
guiding us through the presentation. And Dr. Nalini madam, thank you so
Thank
much
you. Thank you,
for
Shivarti.
for the presentation. Nice presentation.
Thank you.
It was very nice. Looking forward to see you all in our next meeting. Good day. Thank you.
Thank you. Thank
Thank
you.
you, sir. Thank you,
Thank
sir.
you, Shivarti, for the
Thank you
opportunity.
and
Thank
good
you, Hema.
night. Thank you
Thank
and
you,
good night.
madam. Thank
No,
you.
Thank
Good
you,
night.
madam.
Madam,
Thank
actually,
you.
I would like to appreciate Geraldine Sanjay, madam. She is always there. Thank you, madam. Your presence really makes. Uh, and now I am attached to you.
Okay.
Nice
That's
one.
what forensic medicine deals with, not death and dying. So,
No,
Yeah.
as you keep on, interacting more and more, now we start getting attached.
okay, thank you.
Visit Atal Bihari. I will see you there. Thank you.
Uh,
Yeah.
thank you
Thank
all.
you. Thank you,
Thank you.
ma'am. Thank you.
Thank you.
Thank you, Shivurti. Thank you, Hema. Thank you.
Thank you. Thank you, madam.
Thank you.
Thank
Thank you. See you.
Thank you, sir.
Thank you, madam. Thank you.
Thank you.